Thank you very much. I'll be making some general comments to set the stage for the next three speakers in this session. I'll be talking just a little bit about where we're at with the treatment of diabetes 100 years after the discovery of insulin. What are some of the big challenges in the treatment of diabetes, and where are we going in the next 100 years? So I'll divide my comments into type 1 diabetes and type 2 diabetes. I'll start off with type 1 diabetes. So type 1 diabetes affects about 10% of the population with diabetes. The rates actually, interestingly, are steadily but slowly increasing, but type 1 diabetes does not account for the epidemic of diabetes that we're seeing. It generally affects children, adolescents, and young adults, usually before the age of 35, although older individuals could develop diabetes. And it occurs because of an immune destruction of the pancreas, and particularly the cells that make insulin. The big advances that we hope to see over the next, let's say the next decade even, or 2 decades, would be, first of all, regarding prevention of diabetes. So the answer to prevention of diabetes is really based on immune therapy. So in order to prevent diabetes, either before it occurs by identifying those who are at greatest risk of developing diabetes, and we have some markers, biological markers like antibodies that we can use for this, or even an individual when they first develop diabetes, and preventing the complete destruction of the pancreas will really be based on understanding what the immune regulatory issues are, and how do we alter that immune reaction. What gives me tremendous hope is really the advances that have come out of the cancer biology research area. So unbelievable advances over the last even 5 years in our understanding of what some of these immune factors are, and then the checkpoint inhibitors, etc. And I would actually say that the diabetes area is really poised to adopt some of these innovations and really apply them to diabetes. So we hope for some advances in that respect. The second issue really relates to treatment of diabetes. So despite the tremendous advances in the purity of insulins, the types of insulins, even, for example, now the pharmaceutical companies are developing what we call smart insulins, which are insulins that will have less effect when the blood glucose declines too low to really prevent hypoglycemia. Insulin delivery devices, the ways we actually monitor. Despite all of these advances, we still are not able to administer insulin even close in a physiologic fashion the way the pancreas does. So the pancreas is the super smart organ that monitors not just the glucose, but many other signals coming to it on a second-by-second basis, puts the insulin out not just anywhere, but into the portal vein, which is directly into the circulation that goes first to the liver. And that is actually a very important aspect that is conserved across higher species. So when people with diabetes take insulin either by injection or by insulin pump, they are administering insulin under the skin directly into the general circulation. But first under the skin and then into the circulation. So we have to get much better with that. And we're very close now to developing engineering systems of continuous glucose monitoring, where we have little devices. That was an enormous engineering challenge and a stumbling block for many years, but that's really been solved. So there are effective continuous glucose monitors that can be used, and many of them have alarms that tell the individual when the sugar is going too low. And we have insulin pumps, and the algorithms that connect the two have been developed. And in fact, we still don't have this sort of artificial pancreas, if you want to call it that, and I'm not sure if that's the correct word, we still don't have that available, but that's really because of regulatory delays. It takes billions of dollars for companies to have these devices approved. And I can tell you that many people with type 1 diabetes are not waiting for that. They've got do-it-yourself ways of jerry-rigging some of the pumps and the monitors and the algorithms to try and create a sort of a plug-and-play system that takes care of the diabetes. That there are risks to this. These are not approved devices, and medically we can't endorse that. But I can tell you that people with diabetes are not waiting, and there are very active groups on the internet where people help each other. And then the final way of really truly providing physiologic insulin replacement, you're going to hear from my colleague James Shapiro, one of the foremost experts in the world. His group in Alberta and in Edmonton made tremendous advances, first in islet cell transplants, and then the group is actively working on stem cell research. So I won't say any more about that, but that does hold tremendous promise. Moving on to type 2 diabetes, it's really a different issue, okay? So type 2 diabetes affecting more than 90% of people living with diabetes is very much linked to lifestyle issues, reduced physical activity and weight gain. But there's also a very strong genetic component. So I can tell you without a doubt that you can have two individuals who exercise the same, who eat the same, and one gets diabetes and the other doesn't. So clearly that is genetic. So the prevention of type 2 diabetes is going to take something way beyond the biomedical interventions. It really will involve many other aspects, including food security. It will involve urban design, designing cities in a healthier way, giving people opportunities to exercise. It may involve a taxation system, a carrot and stick taxation system, for example, tax breaks for individuals who are able to take advantage of gyms, etc. It will probably or possibly involve regulation of the health food sector, as well as the tobacco industry was regulated. So I think prevention of diabetes is a huge issue and very, very difficult. From a therapeutic point of view, the last 15 years have been absolutely incredible. So going from having only 2 or 3 options of medications to treat people with diabetes, we now have a slew of new therapies. It's just been an incredible area. And you're going to hear from my colleague, Pat Brubaker, in a few minutes. And she and the Toronto group have been at the forefront of the development of many of these new therapies for diabetes. And what's taken us by surprise, but pleasantly surprised, that we didn't really anticipate, to be perfectly frank, is many of these therapies now, the new therapies, have advantages beyond glucose lowering. They cause weight loss, they protect the heart, and they protect the kidney. They're expensive, so that's an issue, but we have many options. And I think the physician now, with access to all of these medications, has a good chance of working with their patient and really optimizing the diabetes care. So you're going to hear about some of these new treatments. And I can tell you, for the longest time, we were absolutely in the dark ages. We had no tools to assist, pharmacotherapeutic tools. We had no therapies to assist individuals with weight loss. And now the field is starting to get very exciting. And there is more on the horizon. So it's a very exciting area. And finally, the last comments, and I know there have been talks in this meeting actually earlier today about the issues of health system design. So this is the other major issue with type 2 diabetes. The issue is that of the 3.5 million or so Canadians living with diabetes, actually it turns out that probably 20% of this population really accounts for 80% of the complications from diabetes and the healthcare costs. And so using data to identify who is it amongst this population, what are the factors that really determine who is at greatest risk. I can tell you we already know that social determinants of health, issues such as people who are elderly, people who, certain populations such as the indigenous population, new immigrants, those living in poverty, social determinants of health, just like COVID, exactly like COVID, are really the factors that determine who is going to do poorly with diabetes. And we need systems, we need data-driven care, and we need improved virtual care and complex virtual care. When I get on the phone or on video with one of my patients, I can adjust their medications, I can optimize their sugar, but I have virtually no capacity to deal with mood disorders, with food insecurity, with poverty, etc. And so you heard about that earlier today, but we're working very, very hard on these systems, innovative systems of data-driven virtual care. So I'll end my comments there and hand over, and I think you've got 3 excellent talks that you're about to hear. So thank you very much and enjoy.
Thank you, Dr. Lewis, for that wonderful opening talk. I especially enjoyed your comments on how the diabetes field can learn from what we're doing in the oncology field. I think there's lots to gain there, and it's a very exciting area. So next, it's my pleasure to introduce Dr. Pat Brubaker, who is Professor and Canada Research Chair in the Departments of Physiology and Medicine at the University of Toronto, and is a Fellow of the Royal Society of Canada. Her research interests focus on glucagon-like peptides in diabetes and intestinal disease.
Good day, everyone. I'm delighted to speak today at this kickoff event for the 100th anniversary of the discovery of insulin, sponsored by the University of Toronto and the Royal Society of Canada. I'm going to be speaking today on some of the challenges that face us with the treatment of both type 1 and type 2 diabetes, and some of the research that is involved in such treatments. So I'm just going to share my screen with you. And I'd like to start off by reminding people that before the discovery of insulin, which occurred in 1921 and 22, the only treatment for type 1 diabetes was a starvation diet. And with the discovery of insulin, individuals with type 1 diabetes were able to survive. However, notably, this was considered to be a cure for death and not a cure for the diabetes itself. So what's the problem with that? Well, the problem is that insulin treatments really only approximate physiology. And we now have a wide variety of different available types of insulin that have both long-acting actions and short-acting actions. But even in combination, these treatments really only approximate the physiological levels of insulin that are seen in a normal individual, as shown here in the purple. So you can see that there are periods when insulin levels, for example, are lower than normal, and periods when insulin levels are higher than normal. And this can lead to both hypoglycemia with short-term complications such as coma and insufficient insulin, which leads to hyperglycemia and long-term complications due to high levels of blood glucose, in many cases for years. And this occurs in individuals with both type 1 and type 2 diabetes. So these lifelong complications are of great concern both to the individuals who undergo these complications and because of the burden to the healthcare system. And the main complications that individuals with type 1 diabetes have, largely as a consequence of poor glycemic control, include retinal disease leading to blindness, vascular and neural disease leading to gangrene and eventually amputation, cardiovascular disease, you can see here the narrowing of the arteries causing strokes and myocardial infarction, and kidney disease or damage as shown here, which can lead to kidney failure. And together, these complications make the treatment of diabetes really quite a pressing issue insulin treatment alone is clearly inadequate given the burden of these complications to individuals with diabetes. So what are some of the approaches that are taken? Well, one of the exciting new approaches is the development of what are referred to as smart insulins. So in brief, a smart insulin preparation is insulin that's embedded in a matrix type formulation that does not allow the insulin to diffuse out in the presence of normal levels or low levels of blood glucose. However, when blood glucose levels rise in the individual, this leads to an alteration in the conformation of this matrix, thereby liberating the insulin and allowing that insulin then to diffuse out to exert its biological actions, including the lowering of blood glucose levels. So this certainly is not yet in the clinic, but is an exciting new approach for the future. Now, one approach that's been taken over the past 15 to 20 years is the development of glucagon-like peptide-1 based therapies. And this is an area of research that's very active in my laboratory. And fundamentally, GLP-1 or glucagon-like peptide-1 is an intestinal hormone that exerts a wide variety of different anti-diabetic effects in the body. These include most notably the stimulation of insulin secretion. So blood sugar levels decrease without hypoglycemia, which is important. GLP-1 also decreases your appetite, so there's reduced body weight as a consequence, something that's a problem in individuals with type 2 diabetes, most notably, and confers neuroprotection. Most recently, GLP-1 is being shown to confer both cardioprotection and renal protection, and also to show some benefits in decreasing fatty liver disease. Now, while some of these are not possible in individuals with type 1 diabetes, who, as pointed out by Dr. Lewis, do not have any beta cells to produce insulin, other biological effects could be of benefit in type 1 diabetes, with all of these being beneficial in individuals with type 2 diabetes. So where are we going with the potential of GLP-1 based therapies? There are new drugs that have been developed that prevent the degradation of GLP-1. So rather than injecting a GLP-1-like molecule to induce these effects, you can also prevent the degradation of natural GLP-1 to enhance the biologic activity of the GLP-1 your own body produces. And something that is of interest to my lab is the notion of GLP-1 based chronotherapy or time-dependent therapy. So some of you may be aware that some drugs are more effective if taken at different times of day. For example, statins are best effective if taken before bedtime. So what has been noticed in the literature is that in normal humans, that GLP-1 release from the intestines is different when meals are taken in the morning as compared to when meals are taken in the evening. And it's presumed that this increased release of GLP-1 is beneficial to insulin secretion, for example, at a time of day when humans are rising and beginning to eat their food for the day. Interestingly, we've recapitulated these findings in normal mice, showing that in mice who eat during the nighttime, their GLP-1 levels are also highest at night. And so studies into this area of research suggest that perhaps a time-based administration of GLP-1 or enhancement of GLP-1 secretion might more closely mimic physiology in the treatment of individuals with diabetes. More recent developments have occurred in the area of novel targets, and this includes most notably the kidney. So while we haven't really thought about the kidney as a target for type 2 diabetes, for example, recent studies have shown that if you target a protein called SGLT2, the sodium glucose transporter 2, you can increase the loss of glucose from the blood into the urine. And this reduces blood glucose levels without having any need to target other tissues. So excitingly, SGLT2 inhibitors are used widely now in patients with type 2 diabetes, to a much lesser extent in type 1, although that could change. And through the increase in urinary glucose levels, blood glucose levels fall, but at the same time, because that glucose pulls water into the urine, blood pressure also falls, and these drugs are now being also found to confer cardioprotection. So again, interesting new approaches to the treatment of diabetes through the identification of novel targets. So I'm going to close my talk today to just say that, as discussed today by Dr. Lewis, prevention really will abrogate the need for new approaches to treat patients with type 1 or type 2 and type 2 diabetes. However, for those 1 in 100 people in Canada and in the world who have type 1 diabetes, and for the approximately 1 in 10 people in the world with type 2 diabetes, we do need better approaches to treat the disease, thereby preventing the long-term complications. So we hear today from Dr. Shapiro about islet, pancreas, and stem cell transplants as one possibility. We'll hear from Dr. Wu about novel delivery devices as a second possibility. And I think, as I've tried to show you today, there are also other novel targets that we really haven't yet begun to think about in our search for new treatments for diabetes, including the liver, skeletal muscle, our adipose tissue, and the brain. Thank you. And at the end of this session, I'd be happy to answer any questions.
Thank you, Pat, for that fascinating lecture. It's really clear that the momentum in this field is great at the moment. There is a lot going on, so thank you for giving such a wonderful overview. So now we're going to move to a presentation from Dr. James Shapiro from the University of Alberta. He holds the Canada Research Chair in Transplantation Surgery and Regenerative Medicine at the University of Alberta, and is also a Fellow of the Royal Society of Canada. His research focuses on islet transplantation and immune and stem cell-based approaches to cure diabetes.
Hi, I'm James Shapiro from the University of Alberta. Thank you for allowing me to discuss the denouement of diabetes using cell replacement therapy. Frederick Banting here was working as a demonstrator at the University of Western Ontario when one Sunday night, late in the night, he had the great idea of ligating the pancreatic duct in dogs. Here's a page from his notebook from October 31st, 1920. The idea here is that he would increase the amount of insulin made by the pancreas and thereby make it easier to extract it. He went on to have other ideas in his notebook, including number 3 there, placing emulsions of the whole remnant of the pancreas in one shot, basically what we do today with the islet cell transplant treatment. Insulin is a marvelous advance. It's saved countless lives. It is still, however, far from perfect. When insulin is injected under the skin, it sits there as a depot. Here's a picture of a patient's insulin by CT scan sitting there under the skin. It's absorbed slowly or rapidly, but far from perfectly, far from normal. As a result of this, patients face wide swings in blood sugar from day to day, and they face risk of end-stage complications, heart disease, stroke, amputations, nerve damage, shortened lifespan, and many other complications, including renal failure. Something must be better than insulin. Inside the pancreas are beta cells inside the islets of Langerhans. These make pulses of insulin and other hormones, including glucagon and somatostatin, over the course of time, and they're able to regulate blood sugar in perfect linear control. When we carry out an islet cell transplant in patients with diabetes, these cells can pulsate in the same kind of manner. And here's one patient, for example, with near perfect sugar control over time. Despite wide fluctuations previously, this patient now has perfect glycemic control. So insulin is not a cure. It's far from perfect. Every 6 seconds, somebody dies from this disease. 20 years ago, we began an experiment. We called it the Edmonton Protocol, where we transplanted cells from organ donors, the same organ donors that provide hearts, lungs, or livers for transplant. We placed those cells after purification and culture into the liver of these patients through the portal vein. This was the drive-through transplant that didn't require surgery. Patients had local anesthetic. A tube was placed inside this vein in the liver. You can see on the x-ray on the right there. And the cells would nest up in the liver, engraft, form their own blood supply, and would survive. But patients must take anti-rejection drugs for these cells to survive. We showed proof of concept by these studies that cell transplant could potentially cure diabetes. This in itself was not a cure. The limitations were the ability to transplant many patients, There are not enough organ donors to go around. Many patients die on the transplant lists. So a supply of cells from organ donors would never be sufficient to meet the needs of diabetes. The need for the anti-rejection drugs is another big downside. Here's Bob exchanging his insulin for a handful of drugs every day to prevent rejection of his transplant. Those drugs, however, have side effects and risks. They increase the risk of certain cancers. They can increase the risk of life-threatening infection, and they can damage the kidneys and other nerves, etc. So they're far from perfect and not ideal for use in children. We're currently working on trials to infuse regulatory T cells into patients receiving islet cell transplants. We're doing this in collaboration with a group in San Francisco at UCSF, Quizzy Tang and Jeff Bluestone, that can manufacture patients' own autologous Tregs. And we ship blood to San Francisco. 14 days later, they ship the Tregs back to us, and we infuse the patient's own Tregs back into the patients. And with this, so far, looking very promising, we're able to use a quarter of the dose of the anti-rejection drugs. And we're hoping by this approach that we can reduce the risk of cancers and other infections, etc., and side effects. It looks promising, but we still have a long way to go in testing it. We're also looking at improving the supply of cells and providing a limitless supply of cells to go around for future patients. There are two different approaches for doing this. One is called ES cells, or cells derived from embryonic stem cells from a 5-day-old blastocyst. Or the other approach is taking adult cells and turning them back. I'll come to that one in a minute. We've been working with ViaCyte in San Diego that developed an approach to generate ES cells from a supply from a discarded embryo from an IVF clinic. And these cells are called PECO1, and we've been able to transplant these cells into patients with type 1 diabetes over the last 8 years now in collaborative trials with ViaCyte. The surgical procedure involves putting postage stamp tiny little devices under the skin in the forearm and on the abdominal wall. And then we can take those cells out at different time points, look under the microscope and see if they're surviving, and also measure if they're functioning in the bloodstream. It's been a very safe approach so far. It looks to be very promising, but because we place the cells inside a device and because we place them under the skin, this is far from ideal, and there are still challenges ahead. What we've been able to show so far, I think very clearly, is that these cells do make insulin. You can see that with ViaCyte, we've been working with a number of other centers, including a center in Vancouver and 4 centers in the United States. These trials are indeed ongoing. Here's a picture from one representative patient where we can see very clear insulin-producing cells and good blood supply in these devices and cells transplanted, the PECO1 cells, at a year after the transplant. And if we look in several of the patients, we can now measure the production of insulin by the C-peptide test in the bloodstream over the course of time. So it looks to be promising and improving as we move forward. Here's one patient at a year with near perfect blood sugar control. I can tell you this patient's blood sugar control was very erratic at baseline and could not be optimized in this way by an insulin injection, suggesting that this kind of approach is helping to regulate blood sugar. Ongoing work with ViaCyte and with a separate company called CRISPR Therapeutics that ViaCyte's collaborating with, we are now together trying to develop a gene-edited product that will be not susceptible to immune attack and will survive in patients potentially as a universal donor source. This looks to be promising. It still has to be tested in patients. The alternative approach is called iPS cells, where we generate cells from patients' own blood and turn them into islet cells. This once seemed like alchemy, almost an impossibility of turning base metals into gold, but now it is indeed possible to turn blood into insulin-producing islet cells that are the patient's own and therefore will not be rejected, hopefully, by the immune system. This is based on the idea that the adult cells in the blood can be turned back in time so that they are like inside an embryo and then can be rechanneled over time into the cells that we want. Professor Shinya Yamanaka from Kyoto University in Japan worked out the Yamanaka factors that can unlock the cells and turn them back in time. And in his first paper, he showed very clearly that skin cells here could be turned into beating heart cells in the dish. This looked to be very exciting. but difficult at first to take forward. Now there are very well defined protocols for taking these forward, these iPS cells, and turning them into human islet cells, using the same kind of techniques that ViaCyte used to develop their PECO1 cells, with addition of various growth factors at different stages over the course of time. It takes 27 days to grow an islet from a baseline cell, like it was in the embryonic stage. So we can now follow these recipes in the lab. These are mini bioreactors, and we're growing human islets here from bloodstream of patients with type 1 and type 2 diabetes. We're able to turn them into these iPS cells and then differentiate them over time using the protocols that Tim Kiefer, Doug Melton, Matthias Hedbrook, Christina Nostro and others have developed in their laboratories. Brilliant scientists that are collaborating and helping to drive the future forward here. And here, for example, in our own lab, we've been able to follow these protocols and make what look like beautiful, almost mature human islet-like cells from the blood of patients with type 1 and type 2 diabetes, transplant these into mice. In the blue line and the green line there, you can see the blood glucose in the mice is normalized over the course of time, and this looks to be a very promising approach. This in itself is encouraging, but it's not the end game. How do we move from mice to people in first-in-human trials, and how do we then potentially expand this up in a cost-effective way to treat all patients with diabetes in the future? Well, our next steps look upstairs in the Alberta Diabetes Institute to the Alberta Cell Therapy Manufacturing Facility that my colleague Greg Corbett runs. Here they have an opportunity to develop GMP-grade cells, and we're working with them now to develop our protocols to take these approaches forward in safety, first-in-human, very small pilot trials. How will we move from those trials to the future treatment of this devastating disease? There are 463 million people worldwide with diabetes in 2020. It's going to increase astronomically over the course of time, and it is the most expensive disease by far. It costs $1.3 trillion to manage diabetes and its complications every year. So how can we magnify these iPS-type approaches up through machinery and technology? We're using artificial intelligence, AI, robotics and machine learning technologies with also some brilliant scientists that we're collaborating with to see how we might address that question. So for example, this company, Lonza, has a cocoon platform that they've very kindly offered to allow us to use in Edmonton and test in the next stages and map our protocols onto theirs. And these are, again, automatic, robotically controlled cell growing devices, cocoons, that will allow cells to be generated. And the vision here is that we could have a room full of cocoons, they call it the orchard, for limitless growth of patient cells in the future to treat all these 400 million people with diabetes. It remains to be seen whether or not this will ever become a reality and whether it will be cost effective. But I firmly believe there are really bright opportunities ahead. Diabetes could indeed be a thing of the past if all goes according to plan, and it will. On behalf of the RSC and all of those listening today and the organizers of this meeting, thank you so much. I do look forward to the discussion together.
Again, a lot happening, and I'm sure there are questions. I know that I have some. For the last talk in this session, we will hear from Dr. Shirley Wu, who is a professor at the University of Toronto. Her research focuses on closed-loop insulin glucagon delivery, cancer, and central nervous system disease nanomedicine, as well as controlled-release dosage forms.
Good afternoon, everyone. Thank you for staying late, and thank the organizer for inviting me to participate in this panel. Following the wonderful presentations by previous speakers about various advances in diabetes treatment, I'm going to introduce a new treatment called Smart Glucagon Microneedle Patch for the prevention of hypoglycemia. Today, we are celebrating the legacy of insulin discovery 100 years ago. Since then, insulin has saved millions of lives, especially those with type 1 diabetes who rely on insulin therapy to survive. Well, about 30% of type 2 diabetes use insulin to manage their glucose levels and complications. However, many people with type 1 diabetes cannot reach recommended targets of blood glucose level, while intensive insulin therapy, which is intended to control glucose concentration tightly, which can lead to hypoglycemia. In fact, hypoglycemia is a serious and potentially fatal complication associated with insulin therapy. It can cause life-threatening conditions in patients and can pose danger for daily activities, such as sleep, driving, exercising, or operating machinery. Therefore, it causes significant anxiety and fears to both patients and caregivers. There are several causes induce hypoglycemia. The main one is insulin overdose or insufficient meals or food generating glucose. Usually the anticipated insulin dose may not meet the need or is too high concentration because the anticipated food or glucose production and consumption may not be the same as predicted. While the mild symptom of hypoglycemia can be managed by taking carbohydrates such as drinking orange juice and take sugar, but the severe hypoglycemia requires therapy and requires assistance from others. Currently, there are only few rescue kits for hypoglycemia treatment. There's no product available for the prevention of hypoglycemia. The early one is the Glucagon injection kit. It requires multiple steps of preparation of solution and injection, which many people may not be able to handle. A newer product is a nasal powder of a glucagon. It is easier to use. We need to spray into the nose, but still requires other assistance for those patients who are already unconscious or having seizures, just like the photos show. Therefore, there is an urgent need for protection of hypoglycemia. We came up with this idea to prepare a microneedle transdermal patch with dual functions, which can sense glucose concentration and release glucagon at low concentration as needed. It can be applied before bedtime by the patient itself, workout or driving, etc. It is easy to apply. It's a painless application, affordable and disposable. It looks like a bandage, like the photo shows. So it can be adhere on the skin and then leave there for required time periods. So in this microneedle patch, there is contains microgel particles which loaded with glucagon. So the microgels swell at higher concentration of glucose, holding glucagon within the microgel. At low concentration, the hydrogel collapse, squeezing out glucagon and force it release from microneedle. As a result, you can see the release rate is much higher at the hypoglycemia concentration. After having tested the hypoglycemia responsiveness, we test the device to find out if it can prevent hypoglycemia for up to 3 hours in between meals, for example. So we applied the patch 30 minutes before injection of all dose insulin and then measure the glucose concentration in the blood. As you can see, with the composite glucagon containing patch, the glucose concentration remains normal range, but then the sham patch without glucagon treated rat, the blood concentration goes to hypoglycemia range. In fact, this effect is due to the glucagon release, as this bar plot shows. Glucagon concentration is much higher when these rat treated with the glucagon patch. We then test whether this patch can protect the subject for up to 12 hours, mimicking the sleep or long hour activities. So we start application of patch at time 0 and at the time 9.5 hours, and then inject overdose insulin. So with the sham patch, the rat blood concentration goes down continuously to a very dangerous hypoglycemia range. But with the glucagon patch, it maintains at normal range. So even if after 9 hours application, there's no much release from the patch. Only when the concentration of the sugar level goes down and the significant release of the glucagon from the patch. That's why it provides protection and raise the concentration. So in summary, the smart glucagon patch is able to stabilize and automatically deliver glucagon for the prevention of hypoglycemia in preclinical studies. The patch can be applied with the current and next generation insulin, either cell transplantation or with other insulin delivery technologies to make a more complete artificial pancreas. Next, to translate the technology to human use, we plan to develop patch for further preclinical testing and to scale up the manufacturing process. And we will pursue clinical trials in the future. So our ultimate goal is to provide a smart glucagon patch in near future that safeguard patients who use insulin therapy and have a high risk of hypoglycemia. Finally, I want to acknowledge the funding from GDF, which support our project, and answer Bendy and the Best Diabetes for supporting our research and the students' fellowship. I would also like to thank the donors, volunteers who have been working with the GDF tirelessly to raise funds and to raise the awareness and the service support to type 1 diabetes patients. Also, I would like to acknowledge the patients and family members who reach out to us to raise their concern, their hope, and encouragement. So they are the driving force, motivating us to work harder and faster to develop this patch for patient use sooner. The last, not least, I would like to thank the lab members, highly talented, hardworking members in both my lab and the Dr. Jerka's lab, whose dedication has made the project successful. With that, I would like to thank you all for your attention. I'll be happy to answer your questions in the discussion session. Thank you.
Thank you so much, Dr. Wu, for that presentation. It's so exciting to see this project advance. And I know that when we discuss it in fundraising activities with our community, it is a very tangible example of how research has the potential to change lives. So great to see that presentation. Thank you. So we're now going to move to an interactive Q&A. I would welcome anybody attending to submit questions through the chat function. And in the meantime, I'll start off, and going back to Dr. Lewis as a starting point. We know now that diabetes is a very heterogeneous disease. So we don't just have type 1 and type 2, but we probably have many subtypes within. So I would love your perspective of what this means, your opinion on the different subtypes, and how this changes how we are approaching improving treatments or even cures for diabetes.
Thanks, Sarah. That's very interesting, and I'm sure you know an extremely difficult question to ask me right off the bat. Let's talk about type 1 diabetes. So one of the interesting things is that the majority of cases go to complete destruction of pancreatic insulin secreting ability, right? So a beta cell function. It can take a few years for that to happen. So at the time that type 1 diabetes is diagnosed, patients actually have some residual insulin secretion, and they can go through what's called a honeymoon phase, where they can actually come off insulin even for a couple of years. It appears to have gone away and then it comes back. Anyway, I think the point there is not every single case goes to completion. Right, and that's the window of opportunity for immune therapy and trying to prevent. So Dr. Shapiro's and his group know this better than anybody else. Having zero insulin secretion is terrible. It's very, very difficult to manage. Whereas one of the great advances from his group's islet transplantation, and which they pioneered in around about the year 2000, wasn't necessarily that patients got completely off insulin, but just giving them some insulin secretion made the management of their diabetes much, much better. So I think type 1 diabetes, one should understand that whereas the majority of cases go to complete pancreatic destruction, perhaps not all do, so you get this mixed group sometimes that in our clinics a little bit difficult to differentiate and understand. Of course, there are probably dozens of different immune pathways that can lead to destruction of the pancreas. So therein lies heterogeneity as well. For type 2 diabetes, it is a diverse group of different causes. The only thing that sort of defines them as having diabetes is in common is an elevated glucose. But that's sort of a catch-all. Where the final common thing is the blood glucose rises, but then there is huge diversity underneath that. Different genetics, different manifestations of what we call the metabolic syndrome, etc. So trying to tease that out is very difficult, and some advances are being made where you're starting to use even novel techniques such as artificial intelligence to really tease out these diverse groups. But there's no question there's diversity. Let me just say that as a clinician, what's really important to me when I see a patient with type 2 diabetes is it's very important for me to make at least a clinical judgment, and we have some clinical tools to do this, as to how insulin deficient the patient is and how insulin sensitive they are. So for example, a person with type 2 diabetes where the onset comes on very fast and they lose some weight, we know that person's going to need insulin quite soon. Whereas a slow, indolent increase with obesity, etc., is a very different kind of disease. So we try to, in the clinical setting, to at least use a few tools to guide us in how best to treat the patient. But there's no question, the heterogeneity is absolutely immense.
Thank you so much for those insights. I do love to open a can of worms on that topic. I don't see any questions come through on the chat yet, so I will continue. Pat, I have a question for you. I would love to know your thoughts on combining the different therapies we have that hit different targets, whether there is opportunity there for additive or even synergistic approaches, or whether this is, as Dr. Lewis referred to, maybe a matter of finding the right drug for the right patient.
Right, that's a really great question, Sarah. Thank you. I mean, unquestionably, particularly for type 2 diabetes, we have this huge sort of pharmaceutical treasure chest now, I would say, of approaches that can be used that target different systems in the patient. And so the heterogeneity makes it difficult because clearly you have to find the drug that works in that patient. But combination therapy clearly is already used, adding, monotherapy, dual therapy, triple therapy to patients as they progress through the course of their disease already exists. But I think one of the new areas of a lot of interest of research right now is the notion of what we're referring to as co-agonist therapy, or even dual agonist or triple agonist therapies, where several peptide hormones, for example, GLP-1, which I spoke about, in combination, interestingly enough, with glucagon, or with another hormone that acts like GLP-1, referred to as GIP. And the combinations of these put together into a single molecule, in fact, can really be synergistic in terms of glycemic control, in terms of body weight regulation. And it's the balance between these different drugs that determines what the net effect of that drug is going to be. So, for example, if you put glucagon together with GLP-1, it is basically neutral in terms of blood glucose control, because glucagon, as we've learned from Shirley today, raises blood glucose, and GLP-1 will lower blood glucose. So it's neutral in terms of glycemic control, but they are synergistically effective in weight loss. So I think that certainly is one new area right now that is under active investigation, with multiple clinical trials going on now with different kinds of balanced and unbalanced agonist combinations.
Thank you. And just staying with you, Pat, for a moment, there is a question from the audience, which is, if there's a link between circadian rhythm and GLP-1 secretion, is it possible there could be a link between the risk of diabetes and shift work?
Yeah, that's an excellent question. There absolutely is a link between shift work or circadian disruption in general and the risk for metabolic disease, not just type 2 diabetes, but cardiovascular disease, metabolic syndrome, high blood pressure, lipidemia, hyperlipidemia, et cetera. So, our bodies are really designed as humans to eat during the day when we are awake, and to fast at night when we are asleep. And we all know that, with the advent of technology, with street lights in our cities, for example, that it's actually rare that we ever go to sleep in complete dark. We have lost significant amounts of sleep time in general. We have social jet lag, not just shift work, but social jet lag, because we are, in normal times at least, going to dinner parties, for example, or going to clubs, university students who stay up all night cramming for exams. All of these things, as it turns out, are increasing our risk for metabolic diseases, including type 2 diabetes. So my lab is actively working on whether or not changes in GLP-1 might actually contribute to that increased risk, because of the really pleiotropic anti-diabetic effects of GLP-1.
Okay, thank you for that. We're really short on time. I'd love to get to the two other panelists. So moving on to a couple more questions. Concise answers wherever possible, please. Dr. Shapiro, I had a quick question about Canada's experience and capacity for cell manufacturing. I think this is already happening, say, with CAR T cell therapy, and obviously that's hugely relevant for what we'd like to see happening with islet replacement. Can you provide a few comments on that?
Glad you didn't ask me about vaccine and production in Canada. Anyway, I think we do have capacity to do, first in human trials. We don't have massive capacity, and I think this will be driven by, how the first in human trials move forward and how successful they are.
Okay, thank you for that. And Dr. Wu, I'd love to ask you a detailed question about the glucagon patch that you're working on, and that is, clearly you can prevent going low, but is there a risk of kind of a rebound effect and pushing someone into hyperglycemia, say if glucagon was released too quickly? Or I actually don't know very much about that, even with existing rescue therapies for glucagon. So can you comment on that?
If there's no glucose sensitivity control, if it's not a smart glucagon delivery, it will raise glucose concentration, especially when the sugar level is very high or it is about hyperglycemia. So at that time, if you apply glucagon, then will raise further. So it's a counteracting hormone, right, with the insulin. So if type 1 diabetes, the sugar level continues very high, but then administer insulin, then will decrease. If this insulin effect has not completed yet, and then add glucagon into there, will counteracting. So the sugar level will maintain. We actually did some testing in animals. So we applied the hormone earlier, and then we found actually, it can goes up. But that's the function, right? It released glucose from the liver. So it depends on how this glucagon is applied. That's why we need a smart glucagon patch. So since the low one, it will release glucagon. If it's a hyperglycemia or euglycemia, so it will not release that much.
So I guess there's the on switch and the off switch is also built in. I see.
That's right. That's right. That's why if we get glucose responsive insulin delivery system, and then we can combine them. So one control the insulin release and the other control the glucagon release. The problems of type 1 diabetes is not just beta cell destroyed, but also alpha cells impaired. So the glucagon patch is acting as a beta cell, alpha cell. So it's more like a replacement alpha cell. But then insulin patch maybe, or delivery system worked as a beta cell. So they need some kind of communication, but the communication is broken in pancreas. So that's why, James want to have an entire islet, transplant, not just a beta cell transplant.
Right.
Right.
Well, I'm afraid we've come to the end of session, so we need to close now, and it just remains for me to thank especially the speakers for your presentations, for attending today, to the RSC for hosting this wonderful day of events, and to those attending for joining us. Thank you so much.
Thank you, everyone.
Thank you, Sarah.
Thank you.
Thanks, everyone.